Well, welcome everybody. It's a pleasure to welcome all of you to the ECMO for Patients with COVID-19 webinar sponsored by Specialty Care. And today we're going to talk about pearls, challenges, and successes in treating patients with COVID-19, supporting them with ECMO. The next slide will introduce our panel. And first of all, I'm Jeff Jacobs. I'm a cardiac surgeon. I've managed patients on ECMO for the past 30 years and directed an ECMO program for 20 years. And it's my pleasure to moderate this panel and to introduce our two key speakers. Our first speaker is going to be Al Stammers. Al has been a perfusionist since 1987. He's currently the Vice President of Clinical Quality and Outcomes for Specialty Care. He's a past president of the American Society for Extracorporeal Technology, AMSEC. He was president of AMSEC back in 2006 to 2008. And Al is one of the most published perfusionists in the world. He's an international authority on quality with perfusion, and he's led the research initiative into management of patients with COVID on the specialty care front. He's going to be able to share with our group on this webinar our experience in caring for close to 100 patients with COVID and supporting them with ECMO. And then our second speaker is going to be Dr. Michael Furstenberg. Michael is the Chief of Cardiothoracic and Vascular Surgery at the Medical Center of Aurora in Colorado. He's well known as an international speaker and lecturer. He's a surgeon, he's a scientist, and he's has decades of experience with ECMO. He's supported a large number of patients with ECMO and COVID over the last several months, and we're very lucky to have Michael share his experience with us on this topic. The next slide will kind of share some information about how this webinar is set up. Basically, there's a Q&A window at the bottom of the Zoom function that allows participants to answer questions. Participants will be able to type their questions into the question and answer function, and then during the panel discussion, we'll be able to answer those questions. If another participant sees a similar question that they happen to like and want answered sooner, they can vote for that question to get moved to the top of the question list. And with that background, I'll turn it over to Al Stammers, and Al is going to share the current specialty care experience with close to 100 COVID patients supported with ECMO.
Thank you very much, Dr. Jacobs, and welcome everybody. It's a privilege to be able to present the information over the next 15 minutes or so on some of the goings on in our ECMO service line. We have 92 hospitals where we're performing ECMO, and I'm going to present tonight on the results of only COVID patients in 20 hospitals across the United States. Back in March 17th was our first patient that we put on ECMO with a positive COVID diagnosis, and within the first 3 weeks we had grown up to 32 cases. Dr. Jacobs was a primary author on this paper that was published a few weeks ago in SIO, and some of the information that we've learned back then, or that we reported back then, was there was a relatively high mortality rate. Almost 2/3 of our patients were succumbing to the disease on or immediately after ECMO. And then we know that the survivors' average hours of support were just under 200. Experimental medications were used in 60%, proning in almost 80%, and very little, if any, convalescent plasma. And the reason I put this up is over the month and a half, almost 2 months now, that we've been collecting data on additional approximately 60 patients, things have changed quite dramatically. So I'm going to present a summary of the descriptive data on these patients before Dr. Furstenberg and Dr. Jacobs will address some of the perils and pearls and pitfalls and successes. So 93 patients have been supported to date. The primary reason is ARDS, secondary pneumonia. 73% of our patients are male, and if we distribute that by gender, we can see that it's really the same age, both in men and women across that. Ethnic distribution, the primary category we see are 39% to Latino population, followed by a quarter white, and then 20% African American, and then a distribution in much lower numbers shown at the bottom. The red graph on the left-hand side of the United States shows the states that we are performing these COVID patients in ECMO. And on the right-hand side, this is the frequency that we're showing. So one of our largest hospitals has 18 patients, actually a 19th was placed today. And then two additional hospitals are in the 14 range. And then we distribute that about half the hospitals doing 2 or more cases, and then a number just doing a single procedure. As far as the distribution, we've reached our pinnacle early April, which corresponded, by the way, with the lowest numbers of cardiac surgery being done in the United States as well. And then, as you can see, over the last 7 weeks, we've tailed off on the number of ECMOs that we've been doing, declining. On the left-hand side here, the picture shows the red, patients, 23 of those who, what we are listing as non-survivors, and then 32 are survivors. So 55 patients were taken off of ECMO, and then 38 patients are currently running. As far as percentage, 58% right now are in the survivor category versus 41, just under 42% in the non-survivor. If we look at the type of ECMO, almost all patients are veno-venous. These other categories shown on the horizontal axis were early on in the experience back in March and early April, and none of those modalities have been had a patient placed on ECMO since about the second week in April. If we look at what devices are used, 42% are using the cardio help, and so they're flowing Quadrox D. So 75% of our patients are using these two entities, then followed by the Levodopa with the Quadrox, and then a few in these other categories. Cannulas being used primarily, 2/3 are a mixture of femoral catheters, and then 23 patients have had dual lumen catheters, which we'll talk about in just a moment, with a certain number that are unknown. Primary anticoagulation is heparin, with DTIs of argatroban and bivalirudin used in 17 patients. And the majority of these have been conversions from heparin to a DTI, although 3 recent patients started on bivalirudin. So we'll see if that's going to increase in the trend analysis. Separating out the remaining of the slides are going to show a separation. There's survivors and the non-survivors, survivors in the middle category, non-survivors on the right. And we could start to see some differences. The ECMO survivors are younger than the non-survivors. There are more that are women in the survivor category. As far as ethnic distribution, 58% of our patients were either African American or Latino. But if you look at the survivor and non-survivor category, the percentages are 61 and 62% in both of those. So we're not seeing a race-related phenomena, either survival or non-survival. And then the further distribution shown below. Comorbidities, we know that patients are at increased risk for COVID, not only by age, but the degree of their risk factors. And the primary ones that we're seeing are cancer, diabetes, and heart disease that differ between the survivors and the non-survivors. If we aggregate the comorbidity summary, we see that approximately 10% or a 30% increase in aggregate comorbidities are shown in the non-survivor group versus the survivor. If we start looking at some of the data in further detail, the PF ratios for survivors versus non-survivors, really no difference there. Proning was seen more in the survivor group than the non-survivor, and CRRT or CBVH were used in the non-survivor group. The experimental meds that we've listed are shown on the bottom. They're IL-6 receptor blockers, antivirals, antimalarials. Steroids were not considered experimental. And we see that there is a difference with most of the categories except the antimalarials. And whether or not nitric oxide or Flolan were used did not differ, seem to differ from between the groups. A higher group of patients in the survivor category received convalescent plasma. And it's interesting, but there were more circuit changeouts. 32% of our 31 patients who were recorded with the circuit information had a change out as opposed to only 14% in the non-survivor. And the bottom right-hand shows that some patients had 2 and even 3 circuit changeouts. If we look at the experimental meds, we see that the IL-6 receptors, again, were used differently. The days average from diagnosis to intubation on the left-hand side is the average information shown just in a bar graph. And then the box plots on the right-hand show the median values. On the horizontal axis, non-survivors are on the left, survivors are on the right. Each one of the dots are representative of an individual patient. And excuse me, in this particular category, yes, this is an individual patient. And then we can see that the whiskers are the 75% outside of the third and first quartiles. So distribution here, median values are longer from diagnosis to intubation in the survivor group. And then from intubation to cannulation, we see about a day longer in the survivor group, showing that perhaps the acuity of their illness is not progressing as fast. And that also was shown on the right-hand side with the median values being a day longer. As far as the days on average on ECMO, the non-survivors are almost 3 days on less than the survivors. Once, however, you look at the median values, those are very similar. If we look at the hours on ECMO, again, we see the survivor group spending longer time period. And back on our second slide, we showed that when we first reported this information back in early April, we were at 192 hours on ECMO for surviving, and now we're at 320. So clearly there's changes going on that are time related to how patients are being managed on ECMO. As far as the distribution of reason for death in the 23 patients, primarily 35% dying from respiratory failure. But then we see a large category of hemorrhage, DIC, and cerebral diathesis with hemorrhage, and an equal number of patients are succumbing due to these coagulopathies that are occurring. And then a smaller number in family decision to withdraw support. Probably these would fit into the top category, and then 1 each in the sepsis, arrest, and multi-organ system failure. As far as the PF ratios, the survivor category now, post-PF ratio is about 205. And then if we look at the status of the patients, currently 17 patients or 53% of those 32 are off the ventilator, and 14 patients or 44% have been discharged from the hospital. The next few slides before I end are just some observational information that, that we're presenting and perhaps can be further looked at in the discussion period. So this is the devices by circuit type that are used on the left-hand side of the survivors, the right-hand side of the non-survivors. And we can see CardioHelp is the primary device that is used in the survivor category. And then while it was the Rotaflow and Quadrox D in the non-survivor, again, we're not really making any inference of this other than just observational reporting. If we look at the cannula use, 78% were a mixed usage versus 65%. And the dual lumen catheters, there's some controversy about whether these should be used or not. The Europeans have reported that it may not be beneficial to be using a dual lumen catheter. And we can see about 34% were used in the non-survivor group versus 22% versus 35. Then looking at heparin, looking at anticoagulation, really no difference seen here. Perhaps some more patients on our Gatroban in the survivor category, and either DIT are shown to be exactly the same. To conclude, what we've learned so far in the first 93 patients that we have, survivors are more likely to be females, they're younger, and they're staying on ECMO longer. Survivors have a higher use of proning and in aggregate experimental medications, and there may be something going on in circuit differences. Complications are frequent with managing these patients, even more so than general ECMO. There's a large degree of volatility, hemodynamic instability with these patients. Anybody who's managed them knows that there are very wide swings in blood pressure management. Coagulation disturbances are seen commonly. We're not going to be talking about that, at least in this slide set, but we know that hypercoagulability is a real phenomenon. D-dimers are nearly triple what the normal level is, and fibrinolysis suppression is not occurring, so patients have free fibrinolytic categories going on, and they also are shown to have large fibrinogen concentrations, more than 2 times normal. And then finally, reduced extracorporeal gas exchange. We see frequently hypoxemia and hypercarbia, and the management of these patients during ECMO on with sweep gas management is much higher than normal patients would be. So with that, I am now going to shift back to Dr. Jacobs and Dr. Furstenberg.
Well, first of all, thank you, Al, for a wonderful presentation of the data. And more importantly, thank you for leading the drive to capture this data across multiple hospitals, all really across the United States, as you showed on your map. Capturing this type of data from so many different hospitals when everybody is so busy taking care of these very sick patients has not been an easy task, and you're to be commended for those efforts. In a minute, I'm going to transition to a dialogue with Dr. Furstenberg. But before I do that, I do want to ask Al one question. We had a series of questions that have come in, and we'll be answering them throughout the panel discussion. But one of the questions came up related to a topic that I've heard you talk about before, Al, which is the differential prevalence of severe COVID, ECMO requiring COVID, in various racial and ethnic groups. And you've talked about that a little bit on some phone conferences that we've had. So before I transition to Dr. Furstenberg, maybe you could comment on that question, since it's something you've talked about before.
I'm glad you're letting Al comment on that first.
Thank you, Dr. Jacobs. And yes, early on, what we had seen was that it seemed the African American and Latino population was being more generally reported to have the severe form of COVID symptomology that required ECMO, and that doesn't seem to be occurring later on. I mentioned a little earlier, 58% of our patients are in either of those 2 categories, Black or Latino, and a quarter are Caucasian, which was higher back in March and April. But the survivor and the non-survivor does not seem to be differential with amongst the races. We're not seeing what's being reported on the evening news and daily, that it's primarily affecting a particular race or ethnicity. But this also could be due to the non-randomized aspect of our care. We are a lot of these centers that are performing the ECMO, and especially in our bigger numbers, the 18, 14, and 14 category, are in geographical areas that have high Latino populations. And then in the Northeast, we have a high African American population. But sorry to take so long to answer that question, but we do not seem to notice a difference, at least by looking at the data, as we did early on.
Thank you for sharing that. I thought that question came up, and I wanted to direct that to you. What I'd like to do now is I'm going to begin a dialogue with Michael Furstenberg, where we're going to go through the different phases of caring for a patient on ECMO who has COVID, starting with pre-ECMO, then during ECMO, then after ECMO. And during this dialogue, I'm going to work in several of the questions that have been sent to us through the QA slot. And if anybody has any more questions, please do feel free to type them into the QA slot, and we'll work them into the dialogue. So let's start with patient selection. And let me ask your opinion, Michael. What is the appropriate indication to put somebody with COVID on ECMO? And simultaneously, what are the characteristics of a patient that might make you say this patient should not go on ECMO?
Yeah, no, Jeff, and I appreciate that. You know, I mean, that's a great question, and I don't think anybody really has a definitive, concrete answer. One of the things that we are noticing, particularly with the COVID population, is that one, sticking to the basics. I think that most ECMO programs, if you look back on ELSO guidelines, some of the published stuff that came out of the EOLA trial and even the CSER trial for the basic indications and contraindications for ECMO in general, I think clearly apply to the COVID population. So in that regard, you know, you don't want to wait too long for patients. If you can try to get to them before they start having the onset of really severe multi-organ system failure and some of the other complications that they have from just being so sick. That's one aspect of it. I think you also have to be honest with your team about, some of the resources that you have. Some hospitals, including a friend of mine from the University of Pennsylvania, shared with me some of their protocols. And a lot of it is a matter of how full your ICUs are. I mean, if you can support, 4 or 5 people on ECMO, then by all means. But if you have a small ICU and putting even 2 or 3 people on ECMO really stretches your institutional limits, you really need to recognize that we're sort of in a disaster medicine phase and understand whether you take care of them locally at your institution, if you're a small group, or stabilize them and maybe transfer them to an ECMO center. Most places are recommending transferring to an ECMO center because you also have to recognize that, it is a huge demand on resources, especially since, as we have also seen now with COVID, as well as back in the H1N1 era, you may have a patient on ECMO for a month. We had 2 guys that were on ECMO for 34 days for COVID, and it really took a lot out of our team. Now, both of them right now are doing well, but you need to recognize the limitations of your resources, and you really want to save this for people that, based upon the data that Al presented, really probably have the best chance. Places are real, even the major centers that do a lot of this are trying to avoid ECPR. People that are, it's one thing if they have a transient arrest, but if they've really decompensated to the point where they're that unstable, ECMO is probably not a good situation. We're starting to learn that, especially unfortunately, the older population, particularly those with a lot of comorbidities, tend not to do as well. Patients that have been on the ventilator for a long time, for those of you that are not familiar with things like the REST scoring system, start using that to help risk assess, as well as, recognize that, things like cardiac failure really increase the risk of having a bad outcome tremendously.
What's the longest ECMO run you've had in a survivor? Is it the 34-day patients you just talked about?
Yeah, and ironically enough, even though they were both put on ECMO several days apart, we didn't realize this until we took the second one off, but they were both, they're both tied for the record at 34 days. And it was, for the perfusionists that I work with, that I think are also on this call, really a hats off to them for the tremendous effort, because it's a lot of work, as I think some of you may know, these can be very sick patients. They're bleeding, they have ventilator challenges. And remember, we're still trying to really learn how to take care of COVID overall. And so it's very stressful, when you're kind of embarking on a journey across an ocean and you really don't know the best path for it. I think we're getting better at it now that we're a couple months into it. But remember, these guys that we had on for 34 days, they're a couple weeks out now, which means we put them on 2 months ago. If you think about where we were in this pandemic 2 months ago, there were a lot of uncertainties, and it really, it was very stressful for everybody, and that's why you got to stick to the basics.
Well, thank you for sharing that. I'd like to go back and ask Al a quick question, and this goes to the role of veno-arterial ECMO, and I'm going to go back to Michael with this discussion after I get some input from Al. In our nearly 100 patients, do we have any survivors with COVID that were treated with veno-arterial ECMO?
No, we do not. We had 4 patients with VA ECMO, and none of them were surviving. That was very early on, within the first week to 2, and we haven't done any more since then. And just getting back to what Dr. Furstenberg had said, our longest survivor, I just looked at that, was on ECMO for 45 days. Dr. Furstenberg's experience, I think, is reflective of that. It just seems like, there's no early termination with many of these individuals.
Thank you, Al. Michael, can you comment about the potential role for veno-arterial ECMO, if it has a role in this setting, and how?
Well, I think, so a couple of things. One is, I'm a firm believer that veno should be limited to people with isolated respiratory failure, veno-arterial for people that have concomitant respiratory and cardiac failure. I think veno-arterial in the setting of isolated respiratory failure probably really doesn't help much. And it introduces a level of complexity in management that could be a real challenge. And I think, borrowing on, kind of Al's, comments and our experience, by the time these patients are really getting cardiac failure, we're dealing with a whole different ballgame. I mean, the respiratory failure that we see with COVID is one set of problems, but we're also seeing and reading about, cardiac failure, which is a completely different animal. It's the cardiac failure is not from the hypoxemia. It's not from, ischemic events that may get better over time. It's not from correctable valvular disease. The things that we see working in VA ECMO overall, we're starting to see patients that have very bad myocarditis, very bad systemic inflammatory syndromes, and I think a lot of it also stems from this whole cytokine storm that we see. So the cardiac failure may in itself be somewhat of a marker of an end stage process that may not get better if you improve the oxygenation, ventilation, and acid-base management that really ECMO brings. It's a different ball game. And those patients, we've even talked about whether those patients, and the one that we had with cardiac failure, we supported on VV ECMO with an Impella. He did not do very well, but I think that there's some growing dialogue that may be a better approach to dealing with the problem than putting people on VA ECMO.
Yeah, I'd like to follow up on that a little bit and ask you a little bit more about if we have a COVID patient who has cardiac dysfunction as well, and we're choosing to try to support this patient. Could you compare and contrast VA ECMO versus VV ECMO with an Impella? Why you think one idea might be better than the other? What the differential risk and benefits might be?
Was that to me or to Al?
That's to you, Mike.
Oh, okay. So I think, part of it is that, especially with the coagulopathy that these patients sometimes see, that VA ECMO is a real challenge from a cannulation standpoint. Technically doing it, especially in an emergent situation where you don't necessarily have the luxury of cut downs and good access. And I think, if you're starting to believe that the concept these patients should be vented, that you're going to probably be adding some type of secondary mechanical support anyhow. And I think that if these patients are going to be healing or recovering at different rates, it does make transitioning them much better. And while I want to say I have no conflict of interest with Abiomed, but I think that some of their technology can really augment the cardiac output in ways that sometimes may make things a little bit easier than VA ECMO. I think that there's a very high profile VA ECMO case playing out in the literature right now of a celebrity. And unfortunately, it seems like he's had every complication known. And a lot of that probably stems from the difficulties in managing septic patients on VA ECMO, limb ischemia, bleeding, all, compartment syndromes, all those kinds of things. And those are tough problems. And if you can get away with that, with other forms of mechanical support, I think that may be a better way of going.
Well, thank you. I'd like to transition the discussion now from patient selection and selection of support type to a discussion about cannulation strategies. And I'm going to start this discussion with Al first, and then we'll go to Mike. So the question I have here is, we've now decided we're going to go on ECMO, and we're getting ready to go on ECMO with a COVID positive patient. I'd like to solicit first Al and then Michael to give us thoughts about the safest way to do this, and what safety precautions that we might not have taken in the past we should take during cannulation in a patient that's COVID positive, both perfusionists and surgeons and really all members of the healthcare team. What do you think about that, Al? Any advice to everybody?
Yeah, thanks, Jeff. And yeah, we, on some of the webinars that have been held abroad, primarily in Europe, the primary reason that was stated, and this was out of Paris, out of France, where they've done several hundred ECMOs, or at least as of a couple of weeks ago. I'm sure there are probably more now. They said to specifically stay away from the use of dual lumens because of safety issue with primarily with the providers, more so than the patients. And I don't remember exactly what the issues were, but they felt that it was just too difficult and to put people at risk. And we've seen that here in the United States. Clearly close to two-thirds, actually closer to 75% of our patients are put on with bifemoral cannulation or femoral right IJ primarily that's being used. And I think that the centers that are using either the Crescent or the either of the dual lumens, the Avalon, they're doing so because they have significant experience with inserting those devices in their general ECMO population. But for the most of us, the majority of centers are using the two catheters, two cannulas, in one in the vein, femoral vein, and one in the IJ, just because of their ease of insertion.
Mute here. So I think, you know,
I'm sorry. Yeah, Michael.
Yeah, I kind of agree with a lot of that. I think, you know, there's a couple things, and from a practical standpoint, one is, you know, some of the current recommendations, you know, sort of avoid cannulation up the head and neck because, you know, there was concerns of whether that increased the risks of exposure during that time period. I think the other aspect of it is almost a little bit of a practical aspect. You know, these patients really need a lot of flow. And even with high flow, hypoxia is still an issue. And I think that there is some concern that even if you can get high flows with, you know, Crescents or Avalons, you know, there is always the question of, you know, positioning of them. And if you don't have a lot of good experience and comfort with them, then you're always questioning whether the cannulas are positioned properly, and the calls in the middle of the night that they're desaturating, and you're worried that they've moved, and you have to get echoes. And, you know, there's a lot of nuances that I think that makes it hard. And I think in general, in talking to people, there's been more enthusiasm for femoral cannulation and kind of staying away from, you know, the airway, and access has been a lot easier from a technical standpoint and more reliable, and especially decannulation as well.
And how about safety precautions for the team during the cannulation process?
Yeah, so we adhere to, especially since we know if we know they're COVID positive, we adhere to very strict droplet precautions. You know, we have an ECMO cart, we have all the supplies all ready to go, and we really just limit it to the bare minimum number of people that need to be in there. These patients, if we have somebody that is looking like they're going to be on ECMO and we're trying to decide over the next couple of hours, we want to maybe prone them first to see how they do with nitric, then we will start to transition them to probably a larger ICU room, one with negative airflow if we can. And then from a provider standpoint, we really just, you know, we try to have the most experienced team in there, you know, doing it with, you know, people that do this stuff day in and day out. You know, I've spent more than half my career in residency programs, and I love teaching, but these are not teaching cases. You know, these are very high risk. They can be technically challenging. Some of these patients, you know, are positioned in a way that barely keep them oxygenating, and just lying them prone to get them cannulated, they decompensate very quickly. You know, you really want to have the A team, so to speak, involved, and everyone's got to be in strict PPE and 95 masks, you know, and whatever they have to make them comfortable in working in that situation.
So I've heard from some programs that once they're on ECMO, they set up the geography of the room so that the ECMO machine is sitting by a window so that the ECMO specialist or perfusionist monitoring the patient and the circuit can do so from outside the room through a window and only come in the room if necessary. Is that a strategy that you've used, and what do you think about that strategy?
Well, yes, we use that, and unfortunately, I can't do it right now, but we have pictures of all this stuff where, you know, the nurses that are actually in the room or spend a lot of time in the room have become masters of writing backwards, because they write all the stuff in black erasable ink on the glass doors, so we can see the drips, we can see all the stuff. We positioned all the drips, all the, the ventilator, the hemodynamics facing out, so you don't actually have to go in. And we do the same thing with the ECMO machine, so that we don't necessarily have to see don't have to go in there to see anything. And if anything, I think, what's refreshing about it is that, some of the staff that were very reluctant to actually touch the ECMO machine have no problem going in and kind of tweaking things a little bit. And especially with stuff like cardio help, where you have all that monitoring, it's pretty easy to see the details, from your appropriate social distancing 6 feet through a glass wall. I would highly recommend that when you do this, you position everything so that you can see it. It may seem obvious, but it took us a few days to getting into this to recognize that we needed to do that. And now it's everybody does it all the time.
Well, that's definitely some real world practical advice.
Yeah.
Let's transition now. We've chosen the patient's going to go on ECMO. We've successfully cannulated. We've got things set up so that we're safely monitoring the patient like you just described. And now we're stable on ECMO. I've had a number of questions that have come in from our audience asking about strategies for managing the ventilator, initially during support and then eventually when we get to the weaning phase. So could you comment a little bit about what you do with the mechanical ventilator and what your strategies are for mechanical ventilation in a COVID patient on ECMO?
Yeah, so I think, talking about ventilation strategies on ECMO is like, talking about religion, at the United Nations. I think everybody's got their own strategies. And I think, again, recognizing that there's a full spectrum of respiratory failure that comes from COVID, and it's not just a simple like aspiration pneumonia or pneumonia. But again, going back to, I think, the basics that we have adopted over the years, and that is slowly trying to get patients down on minimal ventilator settings, minimal amounts of PEEP, minimal amounts of oxygen, try to get to reasonable tidal volumes. And then once you're comfortable with that, then you can start weaning the ECMO circuit. And it could be, from what we've seen, it can all happen within a couple of days, or it's just a slow, every day you get maybe, 10, 20 more cc's of tidal volume. I think, there's a reluctance, understandably, to subject patients to barotrauma and all the consequences of that. But, I would not start weaning ECMO until you're really ready to have a reasonable ventilator setting. The last thing you want, again, as with any ECMO patient, you don't want to come off ECMO with ventilator settings that are not far from being indicated for ECMO to begin with. You want something reasonable. And the ideal patient, which we've seen in 1 or 2 of our survivors actually, is they come off ECMO and then 2 days later they're getting extubated and then home in a week. Everybody's different. This is a very complex disease. There's a lot of heterogeneity, and you can't lump everybody into a single basket, but you got to think with the basics.
What's your target FiO2 and PEEP for decannulation?
Probably about 50 to 60%. The guys that were on, one of the guys that was on for 34 days, we were kind of faced with the decision of he was almost there and probably needed a couple of days if he continued on with the trajectory, but we came off sooner on a little bit higher vent settings than I would have preferred, because the other option was to change out his oxygenator, and we really didn't want to do that. So we were really kind of forced to come off at a level that was higher than what we had anticipated. But really 40 to 50% would be ideal.
And how about the PEEP?
Probably 5 to 7.
Okay.
Again, depending on the circumstance.
I'd like to ask one more question related to ventilator strategies, and this again comes from our audience. This question has to do with the differential types or the different types of respiratory failure that we see in COVID patients. Can you comment a little bit about the different types of ARDS we might see in COVID patients, and then the differential management that would go in these different types of respiratory failure?
I'm not sure I can, well, can you repeat that
So,
again?
so this is something you and I talked about the other day, actually. So not all respiratory failure is the same.
Yeah.
And some people may have more shunting, some
Yeah.
people more have
Right.
more
Yeah.
VQ mismatch. How do you assess that and maybe use differential ECMO and ventilator strategies associated with the different forms of respiratory failure?
Yeah. That is really a tough question.
Yeah.
Because I think if you talk to people that really understand and put a lot of time and energy into thinking about the respiratory failure with COVID, as I mentioned in the previous question, this isn't just one type of ARDS. There are different types of shunting, different types of hypoxemia. We are seeing patients where they're profoundly hypercarbic, but maintaining their oxygenation, and then vice versa. And so it really needs to individualize. I think you still need to think with the basics of the indications for ECMO and recognizing that ECMO is a supportive therapy. It's not meant to treat the underlying problem. So once you stabilize the patient and essentially prevent them from dying, then you can step back and say, okay, how do we want to now address their ultimate lung injury? And I still think that recognizing the key to recovery is you have to let the lungs rest. You have to treat the underlying problem, which I think we're getting better at doing with some of these newer COVID therapies. And I know that's very controversial, but also avoiding really the barotrauma, the acid-base abnormalities, the hypoxemia, and just hope that things get better. But I think you have to, without a doubt, recognize that there is no single ventilator strategy. We've become, probably our favorite strategy, if there is one, if that's the way of describing it, is the APRV mode, where you can really kind of set in some degree of maximum and minimum pressures while also avoiding some of the barotrauma, but also preventing some of the atelectasis. This is a pretty sophisticated respiratory failure, and it's not just putting somebody on a single ventilator mode and assuming that one size fits all.
So the next question I'll ask related to this comes from our audience, and Al has already shared some data. So Craig Pedersen has asked us what percentage of patients are getting tracheostomies and any contraindications or indications for tracheostomy. And Al had answered that he's not aware of any contraindications, but 4 out of 32 patients have received tracheostomy in our series. Have any of your patients, Michael, received tracheostomy? And how do you decide whether you're going to do that?
Yeah, so of the 4, 3 of them are ours. So, one of the things we realized is that we had a lot of oral pharyngeal bleeding for a variety of reasons. Some of it was related to the coagulopathy. Some of these patients, the 2 of the guys, the 34-day guys both got trachs. One guy was on for a less period of time and he got trached, and a lot of it was just dealing with the airway. I think it does make things a lot easier just to get the stuff out of the mouth like we always do, but convincing ENT or somebody to do what is a very high risk tracheostomy is not to be taken lightly. Of the 3 that we had trached, one of them we decannulated this morning and he is actually talking. Another got decannulated at his rehab facility, and the other one is still somewhat vent dependent, but not quite ready for trach trials yet. So I think it does, much like trachs in any other type of respiratory failure, make things a little bit easier. One of the things that I haven't figured out yet is these patients seem to have a lot of head and neck swelling. I don't know why. And it seems, I think we're all familiar with patients that are terribly volume overloaded, and they get edematous everywhere. But it seems, even though we try to do all this stuff to keep their heads elevated and decrease the cerebral venous pressure and all that stuff, their heads and necks are really swollen. So these are not easy trachs to begin with. And You also don't want to do a trach and, and have all this then bleeding from the head and neck, because then that drives everybody crazy too.
That's for sure.
So I'd have a low threshold for people that are on it. Again, going back to the basics of kind of critical care. If it looks like they're going to be on for more than 2 to 3 weeks, you really need to start thinking about early trachs and finding somebody to do it.
Yeah, that's very good information about the tracheostomy. Another question that's been part of a parallel dialogue in our discussion group here has been related to the role of vasopressors in COVID ECMO patients. Mark Mullins has asked this question, and Al has commented that this has been discussed on some of the phone conferences we've held. What's your experience, Michael, with vasopressors? Is there an increased requirement for vasopressors in VV ECMO patients with COVID compared to other VV ECMO patients? And what are your vasopressors of choice?
Wow. Again, that's, I mean,
This is the advanced class, right?
I thought we weren't talking about religion and politics here. I think the vasopressors really need to be titrated for the clinical scenario. If you're sort of on the assumption that these patients have pretty good cardiac function and they really are vasodilated in some degree of septic shock, then as painful as it is, and all my colleagues that are on this watching will beat me up over this later because they know how much I hate it. But I think, norepinephrine and vasopressin tend to be kind of the go-to drugs. But I think you really need to make sure that you're optimizing everything else. If you have very high vasopressive needs, then you really need to make sure that these patients, their preload and afterloads are tanked. You're not missing something. Their acid base is optimized as much as possible. Again, questions about adrenal insufficiency, and you just can't titrate the norepinephrine for a pressure.
Okay, I'd like to now transition, and Al read my mind, into some of the experimental medications and therapies that we have some experience with, and your thoughts on these treatments. And we're going to start with medications and then transition to convalescent plasma and cytosorb. So Al has a picture on this slide of a bottle of remdesivir, which is one of the medicines that's gotten some press lately. Michael, can you comment on remdesivir, your thoughts, and your experience with this drug?
Yeah, so again, early on, it was under the compassionate use. Our first ECMO survivor was fortunate enough to be able to get it. I think, as anybody that's been following this, the jury is still out over the benefits of it in these critically ill patients. I think that it is something that has been shown that if it's going to work, then it'll work by reducing the duration of illness. And, one of the things that I think, we've been having these weekly conference calls talking about this, and we have noticed that a lot of patients have been getting experimental therapies. And I think it's a matter of having an open mind towards trying some of these things in terms of figuring out what's working. Part of the problem, though, is without getting into the specifics, especially in the context of some of the trials, remdesivir you were excluded from the trial or contraindicated if you had renal failure or maybe even some degree of hepatic dysfunction. And unfortunately, as you can imagine, the ECMO patients often have some of that as well. So if you have a patient that does qualify from remdesivir and you can get it, which is a real challenge these days, I would advocate giving it a trial, especially if you can get to people early in their disease.
Thank you. Al, do you, off the top of your head, can you tell us how common remdesivir has been used in our survivors?
Yeah, Jeff, that's exactly what I was pulling up. To give you the exact numbers, remdesivir is used a lot more often than hydroxychloroquine. And in the non-survivor group, I'm sorry I didn't get it up in time, the non-survivor group had higher uses of hydroxychloroquine, while the survivor group had higher uses of remdesivir. And I apologize, we haven't done a statistical analysis to see if that is significant. Back when we had 32 patients, we weren't powered enough to really make a determination, but it does look like that data is trending towards better outcomes with remdesivir. But clearly, there's been a lot of changes that have occurred. If you look at what occurred on a weekly basis with how these patients were being managed, I think the knowledge, since these publications that are coming out are getting through peer review within days and ending up in the literature, are really changing the mindset. So it's very interesting to look at the timeline of what's occurring. And as I mentioned earlier, we have a much better survivability later on in the management of these patients than we did early. Again, it's not true across every center. Dr. Furstenberg centers had great results since day one. But in general, looking at the aggregate of the data, it seems like the combination of remdesivir, convalescent plasma, proning's been highly used right from the start. They tend to be more prominent in the survivor group versus the non-survivor. Again, non-randomized clinical trials. We don't have cause and effect. These are just observations that we're making as this data evolves.
Thanks, Al. I'd like to now throw out the topic of steroids. Michael, do you think there's a role for steroids? Do you think they help? Do you think they hurt?
Yeah.
This is a little more religion politics, but maybe some data.
Yeah. So I think, early on, there was a huge reluctance to use steroids because of some of the data that came out of China that suggested early steroids may have increased the rate of viral replication and some of the outcomes that are associated with that. And steroids in general are very controversial in the ARDS population. But I think especially with some of the people that are on it for a while, but that start going down the pathway of really kind of the different phases of ARDS, I think that there's a general thought that steroids a little bit later on in the course may reduce some of the pulmonary fibrosis that we are seeing in this population, as well as reducing or assisting with some of the pulmonary compliance. One of the things that we clearly noticed with the patients that have been on for a couple of weeks is that their pulmonary compliance and their airway pressures are extremely high, and it's very difficult to oxygenate and ventilate. Or it's actually, even before you get to the oxygenation and ventilation phase, it's difficult to just put air in and out of the lungs, very low tidal volumes. And you can probably get a very dramatic improvement for starting steroids in this population. I don't think anybody really knows what kind of steroids yet, as there are a couple of different kinds, but it does improve compliance. And Jeff, they'll probably, kick me out of the Society of Thoracic Surgeons for advocating steroids in any population, but it really does, I think, help.
Yeah,
and we're going to see more and more positive data on that.
Yeah, recent data supporting exactly what Michael just said. And just looking at our numbers, 56% survivors were on steroids, primarily Solumedrol, and then prednisolone, and then 40% or 41% in the non-survivors.
Okay, in the last 5 minutes that we have, I'd like to cover two more topics, which is the convalescent plasma and CytoSorb. So Michael, maybe first you could tell us about your thoughts on CytoSorb, if you've used it at all, if you think it would be beneficial. That's what the beautiful picture on the slide is a CytoSorb device.
So we've used CytoSorb in a handful of patients right now, although only one ECMO patient. And our basic hypothesis was that if we could use CytoSorb early, it may actually prevent patients from going on ECMO. That I think the jury is still out on that. By the way, full disclosure, when I started reading about CytoSorb and hearing about it, I thought this was going to be a real thing. And again, disclosure, I bought some stock in the company. That's how much I believe in it. Not enough, but nevertheless. The base, and there's a variety of similar therapies that are out there. And when I mentioned it to our ICU group, our nephrologist went crazy over it. They love the idea. And if you look at the basic science behind it, it really is pretty impressive. The premise is that it filters out some of the inflammatory mediators and the interleukins that have been correlated with some of the real cytokine storm complications that we are seeing in ECMO. The most recent patient that we did use a combination of ECMO and CytoSorb, we were actually discussing some of the levels today. Pre-ECMO interleukin was, I believe it was 150, which normal was essentially 0. So that's a very toxic level of interleukin-6. Within 24 to 48 hours of cytazorb, that came down to, I think it was about 15 today.
This is a patient on ECMO.
You're right. And that clearly correlated with what has been seen in the cytazorb literature separate from ECMO, and that is a dramatic clinical improvement. This patient had, a very high pressure requirement, vasopressin and high doses of norepinephrine. They are now minimal. We don't have them completely off, but all the fluid that he accumulated in the first pre-ECMO couple of days, we have been able to take off. He's needing renal replacement therapy, but we were able to take off a lot of volume, and a lot of that temporally seems to be related to the clinical improvement with reducing his inflammatory mediators. When we put him on ECMO, he was his temperature was 98.5. We had to do a lot of active cooling. We have been able to get him off of that component of the therapy. It mechanistically, I would, a little bit out of the spectrum of today's conversation, I would encourage, again, full disclosure, but I would encourage people to look into this therapy. And whether it's cytazorb or some of the other filters that are out there, I think this is going to be the wave of the future for dealing with some of the septic states.
You spliced it into the circuit?
Yes.
Pre-oxygenator or post-oxygenator?
I'm trying to remember the config. I think we bring it in pre-oxygenator. I
don't know that it even matters. I was just curious.
To be honest, I don't think it really matters offhand. It can handle the pressures. The key is that you have to maintain the anticoagulation, and so what we've done, all of our patients have needed it in the context of renal replacement therapy. So we're kind of splicing it in to the renal replacement circuit. So,
all right. We're coming up on the hour, and I've got one quick question. Can you give us a 60-second answer on convalescent plasma therapy and your thoughts on that and your experience with that?
So we've used it quite a bit, independent of ECMO and ARDS. I think there's some interesting data just coming out in the past couple of days that is questioning the effectiveness of it. I think a lot of it stems from, again, mechanistically, how does convalescent plasma work? And I think that conceptually it is something that kind of helps you very early on in the disease process to potentially attenuate some of the problems. It is not a silver bullet solution for everything. So I think that there is a role in it in these very sick patients, in sort of the walking wounded or the non-ECMO critically ill. I think the jury is still out for that. But it's, I think people are still defining that role, but I think it is going to be helpful in selected patients. And I think that's the nature of all these things that are being out there. We're going to start seeing objective roles regarding, the timing of the disease, the comorbidities, how they present, and we're going to need to be much smarter in how we tailor those therapies. Including, I read an interesting paper that came out of India, and again, not wanting to go down the real politics of all this, but I think in some of the major cities of India, they were giving prophylactic HCQ to high-risk members of the police force that came in contact with these people. And they had some observations that really did suggest that prophylactic HCQ in high-risk patients may actually be beneficial, which is contra to some of the other data that's coming out there. And I think we're going to see selected populations being treated. We're going to start seeing COVID-19 being treated more like, I think, cancer therapies, where you're really going to have to individualize the therapy based upon the stage of the disease and almost not necessarily cell types, but how the virus presents.
Well, I'd like to thank both of our panelists, Al Stammers and Michael Furstenberg. This has been a very high-level discussion that I've truly enjoyed. I think that what we've learned here is that there's known knowns, there's known unknowns, and there's unknown unknowns. And it's a rapidly evolving state of the art. I hope that our participants, over 200 that have stayed with us the entire hour, benefited from this. A survey is going to be sent to the participants. We'd ask you to fill it out. And also, I tried to triage as many of the questions as possible. There's some I did not get to. If anybody has any questions that we were unable to get to, if they attach those to the survey that they fill out, or if they email them to us, we'll do our best to get back to the participants with some type of an answer from either Al Stammers, Dr. Furstenberger, or myself, or the combination of us. And with that, we'll wrap up this panel. Thank you all very much. And everybody go out there and cure some patients.
Thank you, everybody. Thanks for joining us today.